It's nice to see some of your guys' faces. I see some people I recognize, but a lot of people I don't. So I'm Dr. Jayasurya. I go by Dr. Hershey. I did my family medicine training at Sparrow back in 2011. And so I've been out since then and doing various things. But just recently, as of last year, left to start my own company called Bridge Care Specialists, and we specialize in transitional care. So I am going to be talking about transitional care management and health literacy as it pertains to that. So let's see here. So the main topics that I want to make sure that I cover is how and why transitional care can drive better outcomes, where health literacy falls into the equation, and then strategies for success. So probably most of you second year, third years have heard of health literacy. It's usually used as a way to, describe how aware the patient is about, their medical conditions, their options. Also it's often used to describe how compliant the patient is too, when I'll see in notes low health literacy, and that's simply because the patient doesn't want to do what we've asked them to do. But you're going to definitely hear more about this, as it's one of the quality measures that CMH is looking at, not CMH, Medicare is looking at. So it goes into different pieces of, different factors like MIPS and stuff like that, but not specifically stating it's just health literacy, but you'll see more and more information about this. And then I'm going to present some real life strategies for success. So things to consider. So I get referrals from Sparrow, and I see some of your guys' discharge summaries, and they're really, really good, really phenomenal work that you're doing from the H&P all the way to the discharge. Not all doctors have the quality that you guys have, but when you're thinking about, a patient being discharged on the inpatient side, and then also thinking about it from the outpatient side, when you're seeing patients come back from a hospital stay, there's a lot of the things that I'm talking about here and things to consider are going to be similar on both sides. So on inpatient, you're looking at, who's high risk based on their complicated health history, what's their prognosis, how complicated is that? How could we optimize once the patient gets out of the hospital? How do we prevent their readmission? How do we help them navigate? Some of the medicine can be really complicated if you're, again, low health literacy, but even if you have some degree of health literacy as well, it's a really complex, convoluted space to navigate. So does the patient know that a cardiologist is a heart doctor and why it's important for them to follow up? And having some idea of what happens when your patient leaves the hospital, where are they going? Do they have access to be able to pick up their prescriptions? All of these are things, from the inpatient side, you're considering. But then when you're on the outpatient side and you're seeing that patient within that first 7 days, ideally, these are questions you want to answer also, because it's going to prevent that 30-day readmission. So the benefits of good transitional care management, again, we're going from a quantity-based care model to a quality-based. And TCM, I'm going to explain to you how it can benefit clinics, patients, and payers. So there's lots of interest in transitional care management as well. So the advantages to patients, they're getting out of the hospital now, they feel more independent, they want to be at home. Patients oftentimes will opt for home care if they are able to get it covered through their insurance. And that's where caseworkers are, helping to navigate that, those answers there. With good TCM, they get a lot of their questions answered that you might not have had time to do on inpatient. And I admit, I've been working in the hospital inpatient system too, and it's really it's busy, right? You have like 18 to 20 patients a day. You might not have the time to sit down with them and really explain what diabetes is and, why they have to take X, Y, or Z medication. So TCM is a great point where you can do a lot of catch-all and fill in those gaps. You get increased engagement because now you're out in the real world, with the patient, whether you're seeing them face to face in the clinic or you're doing a telehealth visit. you can access the community resources. So for people in the residency that are not aware of a lot of the community resources, there's different fairs and events that you can attend that if you talk to your residency director, they can give you the know of. One is at the MAC building, and it'll be different organizations coming to present what resources they have to offer, what pharmacies deliver meds to home. Like Central Pharmacy, I know does, and there's a few others in the Lansing area. So when you talk to a patient who has mobility issues, maybe that would be a great option because they might not be able to pick up their meds for another week or so until they have transportation. And then good TCM also provides personalized care. So you're looking at that case not just from the hospital checklist, but you're saying, okay, now the patient is out. This is the wound. How do we figure this out based on where the patient's living, what resources they have, all of that. So advantages to the system. You probably hear a lot about readmission rates and bringing those down. And the reason is because, especially with DRG billing and such, readmissions for the same diagnosis, Medicare doesn't pay for that, right? Or they have a huge deduction for it. So we're talking about just in the US here, this was for 2020, 17 billion per year. And this was readmissions to inpatient. This is not including urgent cares and ERs. So 1 in 5 Medicare patients are readmitted to the hospital within 30 days. If they have kidney issues and CHF, that number can go up to 1 in 3. So this is a huge issue. So advantages to providers, again, transitional care management, and then having good health literacy program within TCM can really be advantageous to providers, whether it's from the hospital side or the outpatient side. So who are our risky patients? Obviously, we don't have the time to be able to, capture all of our inpatients, especially if we're working on inpatient and then doing clinic and making sure all of them can come in. But you can stratify based on risk, right? And so we're looking at a number of factors here. And this is research is all across the United States saying, okay, these factors here is what is going to drive people to come back in that first 30 days. So poor health literacy, poor support network, access to care, comorbid conditions, that's the majority of our patients, I know, previous admissions within the last 6 months, a weekend discharge. For the newbie interns here, this is so exciting to see the hospital on a weekend. It goes from like bustling and busy to just a skeleton system. And especially at Sparrow, there's, I want to say, a few dozen case managers during the weekdays. On the weekend, it goes down to 2 or 3 for the entire hospital. So that's a really tough place for them to be able to try to navigate, for all of those patients, all of those beds, a good care plan for everybody to discharge. They have functional limitations. That's a really big indication that patients will come back into the hospital because something will often get missed. In terms of being able to pick up scripts, or they'll have some sort of injury once they get discharged due to deconditioning, and then obviously poor sleep in the hospital. We don't let people sleep, so they're quite tired and they can have delirium. Substance abuse, I don't see much of that in my position, but I know that's one. Lack of social support, and then over 65 years of age. So we're talking about, again, those Medicare patients specifically. So the importance of time. For a 99496, which is a TCM visit within 7 days, that bills out to about close to $200. A TCM visit within 14 days bills out to about $130 for Medicare in our area. So to do TCM, one of the most important things is to do that day 2 point of touch. This can be with staff members at the clinic, at your outpatient clinic. The goal is, hey, the patient just left the hospital. We're going to touch base with them and see, is there anything they need right now? Are there meds that we're missing? Do you need, some extra care, the home nurse to come out sooner than later? Do you actually need it delayed? Are you going somewhere different that you need your meds sent different place? This visit right here, or this touch point, is super important. then ideally, you want to try to get the complicated patients in within that first 7 days. And you're going through their meds, you're reviewing the hospital stay, answering their questions. And then on our end at Bridge Care, we're helping people establish with PCPs. So you might see referrals from us, for patients that are needing a new primary care doc. So, and then between 7 and 30, at Bridge Care, we try to do at least 2 to 3 touch points with the patient, making sure their recovery is going well. There's nothing else that they need. Oftentimes at this point is when we do family discussions, if there's, involvement with the caretaker. And then we do our graduation visit where we're saying, okay, it's been great taking care of you for the last 30 days, because that's what our service is only up to 30 days. We're going to give you a warm handoff to X, Y, and Z doctors. These are your follow-up appointments, just so that and if you need help with any of the, future events, you can definitely give us a call. But that's where we've tapped into home care, we've tapped into community resources, and we're giving them a softer landing than when they first just came out of the hospital. So keeping in touch with patients, a robust TCM program will ideally be engaging for the patient. So we send out a welcome email, next steps email, graduation email. In between, if patient has questions, they're messaging us and then we're responding to them, because various random things can happen once they get home, And I had one patient just recently got discharged from Sparrow and is back home. Before she went into Sparrow, she was washing her boils on her leg with hydrogen peroxide and letting them just drip down into a basin. And she was like, I don't know how it got to be this way. It just slowly got worse. And then I was like, well, this is normal. I should be doing this, And then she's getting back home and she's like, should I start that up again? And it's just like, she texted us, and said, should I clean my wounds that are kind of healing now with hydrogen peroxide? Is that a good thing? It's like, please don't, we can send in some better stuff for you to the pharmacy. So it's things like that that you can catch. And it's not to say you have to be available 24/7 to patients, but them having an access line to you guys is going to really help with the fear and uncertainty. That is one of the things I heard when I was first intern. I said, geez, I was with the attending and I was like, this is so ridiculous that this patient is coming in for this reason. It's like, it's such a minute thing. And they looked at me and they said, Hershey, everybody has a different threshold for fear. And it's when that's met is when they'll come in. And unless you address their fear, they'll keep coming back in. So sure, we can judge them for what their threshold is, but fear is fear and they're afraid and you need to address it. And that really stayed with me because, what is a patient afraid of once they get home, making sure we're addressing that, because they might have gone in the hospital because, they had stomach issues and they're worried about cancer or something. And then they're realizing the troponins are elevated. Now they're coming in for a chest pain rule out. Then they get discharged after ob stay. Nothing was, done about the stomach and they're still worried about that. So following up with that, because that's going to be a quick bounce back right back to the hospital because their main concern was not addressed, right? Being a support network, again, these are the common questions we get asked once patients are discharged. Is this normal? What is this medication for? Is it important that I take it? And then should I be worried based on XYZ symptom again? ER versus urgent care. This is something I really try to push on outpatient doctors to explain the difference between the two. When is it appropriate to go to the ER? When is it appropriate to go to urgent care? When is something a clinic that you can wait to do an outpatient clinic visit with you guys? So explaining in the terms of seriousness, and symptoms is really helpful. And then explaining in words that are health literate to the patient. For my CHFers, we talk about a seesaw with fluids, right? On one side, you get too heavy with fluids. On the other side, you are too dehydrated. And I explained to them, the body is amazing when your heart and your kidneys are working well because it's able to keep that seesaw perfectly balanced, with your fluid amounts in your body. But as soon as your heart or your kidneys or both go, you're tipping that seesaw one way or the other. And that's simply, when you're tipping it, the medicines we give for CHF, they work for 12 hours, 8 to 12 hours at a time. So it's not like the body, which is just on a second by second basis managing it. So yeah, when you come into the doctor, it might feel like, we have no idea what we're doing because we're constantly changing your meds, but it's really based on where you are on that seesaw. Are you too fluid overloaded? Are you too dry? And explaining, checking their weight on that scale to again explain, when you're too fluid overloaded, you're getting over 2 pounds, and then you want to take some extra, diuretic. But otherwise, sometimes you might be too dry and you got to drink a little bit of extra fluid. And so explaining things like that in layman's terms, I do a lot of house analogies, with the body being a house, the blood vessels being the pipes in the house, talking about a clogged pipe to the heart is a heart attack, a clogged pipe to the brain, is a stroke. And that's why, things that can clog your pipe because it's a living pipe, diabetes, smoking, hypertension, high cholesterol, and putting in that term, patients are like, oh, so even though I don't feel my blood pressure, it's like, it's important because it can do damage from the inside. And they're like, yep, exactly. That's why, we asked you to come in to talk about your blood pressure. It's because we want to prevent those events. So putting it into context for them. And that's normal, right? Like if we go into a car, shop and they're telling us all these things about fixing our car, our first reaction is, are they trying to get more money from us? Is this actually something we should be concerned about? And if the person takes the time to explain, why it's important, and especially if they show you, where things are going wrong, you're much more likely to have trust in that person to actually follow through with their recommendations, right? So 9 out of 10 adults struggle to understand health information. In general, most people are at a 3rd grade reading level for health information. We can go up to a 6th grade level based on, if they've gone to college or they've got, higher degrees than that. But 3rd grade to 6th grade is not, that great of a health literacy level for most people. So using plain language, using analogies, pictures and visuals. I try to, at the end of my visits, try to say, okay, can we talk about 3 things that were important during our talk? What 3 things are you taking away from this? Or if it's a lot of stuff, I'll say what 5 things or whatever. And then the teach back method, which I'm sure they'll teach you if you haven't already learned it, is asking the patient to say, hey, I know we went through a lot of stuff here. Can you regurgitate back to me or tell me back to me, what your understanding of it is? So being a resource, knowing your community, I mentioned that, recognizing social and behavioral factors, the social determinants of health, collaborating, communicating with other providers. This is something that ideally we could do more of. It's harder and harder, with the number of patients they're wanting us to see. But calling the cardiologist, verifying, if they come out with 2 beta blockers on their discharge list, is this really what they wanted? Because the patient's not doing so hot, they're getting dizzy, can I take one off? And just clarifying things like that is ideal, because that's going to, again, they're going to get low blood pressure, they're going to fall, they're going to end up in the ED. So our company is purely virtual in nature, so we get referrals from all over Michigan hospitals. And I have to say, TCM in your future careers, to consider doing more TCMs as virtual appointments, because 1, the patient just got home from the hospital. Last thing they want to do is go back out and get back into a hospital setting or a clinic setting or a medical setting at all. They haven't slept, they're tired, and a lot of my appointments are in the evening time. They've slept through the day. Now at their evening, we're waking up, we're talking then. And then transportation doesn't have to be an issue. And it's just a lot more cozy environment, especially, if you have the visual piece. There are bills right now in Congress to just do the audio only to get that covered through Medicare. There's a great deal of support for that because it comes down to an access issue, because like I have people that are in Escanaba. I had somebody today that was a D city that I had never heard of, but it's up in the thumb, and like they don't have internet, they call it Wi-Fi, they call Wi-Fi, and they're like, we don't have that. It's like, that's okay. We can talk on the phone. So it's really nice to do this, from a telehealth perspective. Getting to know the institutions that discharge your patients, so having worked at Sparrow, I know Sparrow somewhat better than most other hospitals, but now I've gotten to know the McLaren discharge people, and just say if you're going to do just outpatient, that's really helpful for the hospital systems or the discharge planners to know what you can and can't do on the outpatient setting. Because you'll see patients going into the ER and the case manager's working and saying, I don't know if this can be done outpatient. And oftentimes the answer is yes, we can do that outpatient. We can have home care come out and give them an IV bolus. We don't have to have them be in observation. So just informing them of the things that you can do on the outpatient side will be helpful to the hospital systems. So these are 3 unique things that we offer when we're doing telehealth visits, and simply because the patient's in their home, we have the patient bring all of their medication bottles to the camera. We're going through it one by one, seeing where they're keeping their meds. Is it just all over the house, or are they having it organized, helping them create pill boxes, doing a home walkthrough to look for areas that they can fall, rugs, tassels, steps, all of that. So we just have them flip their phone around and we're just walking through the house with them. And then a fridge biopsy, especially for new diabetics, going through their fridge or their cupboards and saying, what's that over there? How do we read a label? What should we be eating instead of, whatever it is that they have? So again, it's not perfect. You're not, giving them all the information they're going to need for the rest of their life, but it's creating at least a layer of paint that when they see their regular doctor, they'll have a launching place to ask more questions. When you're creating your own, staff, once you get done with residency, making sure like your MA, your social worker, all of them are able to think creatively when patients are calling in with unique challenges. Because the number one thing that really makes my eye twitch is on the primary care side, the patient will call in and the initial response is, please go to the ER. Please go to the ER. And it's like, let's talk to the patient, see if there's something we can do that can help this and to help the patient stay home. Because as we get older, research has shown time and time again, especially in the PACE research models, that if patients stay at home and they have less hospitalizations and they don't go into nursing care, they actually live longer and have less medical issues. So, and 80% of patients want to die in their home, but it's that number that die in the hospital. And that's something we need to consider. So this is just information to contact me through Bridge Care. And for you guys, anybody that you can't take in your primary care office, so essentially Bridge Care, we take anybody who doesn't have a PCP and they need to be bridged during that time. We do all the home care orders, IV antibiotic management, do all the refills for that first 30 days and get them a PCP. So you might get referrals from us, like I said, and then anybody you're seeing on inpatient, if you can't get into your clinic in that first 7 days, you can definitely send our way and we'll try, when we take all insurances, so we'll try to get them seen. So, good, I have little bit of time here. Let me see. So I do want to show you guys. Let's see. So this was something I did at a conference where I was walking through with the people at the conference and saying, hey, let's pretend like we're at a clinic visit. We're going to do a mock walkthrough as a low health literacy patient. So before the appointment, they're given a bunch of paperwork. And for somebody who's low health literacy, and it could be just low literacy period, the paperwork can look like this. And they're like, there's a way to figure this out, but I don't know how to do it. And I don't know how to answer it. And simply by getting a little bit of help, you'll see, that they could actually figure out what you're asking of them. And that's something to consider when patients don't fill out their paperwork. Is it because they didn't get it? Were they lazy? Or is it because they actually can't understand it or read it? Directions to the clinic. This is one I love. When I go into a new hospital system to talk to case managers, I look to see how complicated it is to get to the room I want to get to, because here we are as healthcare professionals. And if we're getting lost, man, that's a poor system that's built, right? The patient's easily going to get lost. So I gave the directions at the conference to start at the front door, to walk, shake hands with the nurse, hit the podium, have a seat. And it was just something for fun, but it was explaining like how complex our buildings have become now for patients to navigate. So when you're thinking about in the future, you might be in hospital administration, you might be creating your own clinic, or you might go into clinic that you can help to manage and change policy, how systems are designed, so screening for literacy and language skills, providing assistance for paperwork, and providing directions and color-coded uniforms are just some of the ways. We find that if people can't read or do numbers, they can still know their colors. It's interesting, New Zealand has a project that they're doing across the board for their grocery stores. They have red, yellow, and green in terms of how healthy a food object is. And they're finding that patients are choosing better if they're color coded. And this is our Army does this too. It's like when cadets go into the cafeteria, they'll say you can have 2 green things, 1 yellow thing, and then for this meal, and you can have 1 red thing for the whole day. And it's the easy way to just explain, what's good and what's not good. So colors are a great way. Here's a map with everything color coded for a patient. Again, it's still a complex map. It's a complex building, but it makes it a little bit easier. So your appointment. So now you're in my clinic here. You're going to see Dr. Hershey. You've got your copay. You got your paperwork done. I ask you for some extra money. You don't really understand why, but you pay it. And then you're explaining why you're here. Your difficulty in breathing. You live in a house with 3 smokers. You're allergic to your cats, but your daughter brought home a stray 2 weeks ago. You're worried about your symptoms since your father died of lung cancer. And now we're at our appointment. And we say, okay, what brings you in? We do vitals. We say, do you smoke? Okay, here's the prescriptions we're giving you. You know what? We might have you follow up with the lung doctor and then come back in 3 months or maybe 6 months. And then here's a packet of stuff to read about smoking. And so the patient leaves. Average for a primary care visit is 7 minutes face-to-face with the patient. So when you think about in the US, what we can cover in 7 minutes, that's an interesting thing for us to try to figure out for the future. How do we incorporate health literacy either in that 7 minutes or expand that time that we're actually face-to-face with the patient? So in this example here, no screening for literacy to see if they can even read the material we gave them. We didn't have the patient do the 3 asks, no upfront information on copay or insurance. So it's like going to that car dealership and they're like, you know what? Give me $100 and then I'll talk to you. And it's like, wait, why? So again, providing that information, building trust, right? No discussion on how much time will be spent with the provider, no teach back, no time for questions. Medications were just prescribed, no talk about what they were doing for the patient. And then the main issue wasn't addressed, right? The patient's worried about cancer. They're leaving still worried about cancer. The Ask Me 3, I'm not going to go into this, but that's something you guys should look into to make sure that you're addressing with each patient. Setting clear expectations, so honoring concerns. This is the lingo that I've created in the last 10 years. I tell patients, they'll come in and they'll say, okay, I'm worried about this lump on my breast and I can't breathe and my chest hurts and also I need refills on my psoriasis medication. I'm like, okay, whoa, let's break this down. What's most important? Because I want to do justice to your concerns and issues. But if we're going to talk about all this, I'm going to be confused. You're going to be confused. Everything's going to be confusing. So let's break these up to what's most important for you to talk about. I'll tell you what's important for me, and we'll see what we can do, in this 15-minute appointment, and being upfront with them about that. When I was medical director at a hospital, I had this up on the wall. Again, this could be more health literate too now that I'm looking at it. So 15 minutes appointment, 1 issue, 30-minute appointments, 2 issues or a complex issue. So you can definitely make this more color coded and prettier, but it's again providing that education to patients. Teach back, you're going to learn more about that. And here's a picture of the pills, if you haven't seen it, how they're delivered to homes in little bubble packets, and it's really nice. Here is a great way to present medications. You know, again, we have the picture of the medication, what it's used for, morning, afternoon, evening, night. It's super clear then. That's what I really like. Offer note-taking to patients, so making sure you have pens and paper in the clinic room. Asking if, especially with an older patient, if they'd like to bring a friend or family. And then have support staff do the recap of the visit. Again, you're the most expensive piece in the clinic. Your time is the billable time. So they're going to ask you to see the most number of patients in an hour, right? And that's probably not going to change anytime soon. But you can train your staff to do a lot of the recap and a lot of the teach back, and they can go in and finish that visit for you. And it's actually nice when it's somebody else coming in, because the patient feels more comfortable saying, actually, I didn't understand that. So, and then the staff member can reach out to you if they have questions. But again, depending on how much time you put into teaching your staff, they can do a great job, you know, in making sure the patient's questions are answered. So next, for a post-appointment, we find out, but we don't find out, the patient finds out inhaler not covered. You know, the blood pressure medication was covered, so started taking it the next day, but they don't have blood pressure cuff and they don't know how to use it. So still having difficulty in breathing, shortness of breath, but now also a cough. Didn't know that was a side effect of the blood pressure med. So the cough is scaring them and they're going to the ER. This is a great quote by Albert Einstein. Insanity is doing the same thing over and over again, but expecting different results, right? I'm sure in residency, you guys have experienced that, where it's like, oh, something has to be different here this time. We can't expect, you know, this patient to do something different if we're not doing something different. So we find that patient satisfaction is linked to health literacy, you know, making them feel engaged and empowered, having them be comfortable asking questions, being confident in making decisions, getting that explanation. So how good are we at this? This is how good we are. This is from 2003. I couldn't find more recent data, but we're about 12% proficient in actually doing good health literacy in a way that makes difference to outcomes. So let's see, I'm not going to do that. I'm not going to do that. There's lots of resources to find better ways to do your patient appointment that won't make it longer. A lot of this stuff, you can find ways to actually keep your visit short and still provide the information you need to with patients. You might have to divvy up some of that work to your care team, but you can still have a really successful patient visit that is with good health literacy to it. So this is something I recommend to all residents to do. Do a walkthrough of your clinic with the patient or by yourself. Access your practice, get to know how the patient might learn who the providers are, what the processes are, what the patterns are. And specifically, you can keep a sheet. This could be a QI project if that's something you have to do for residency, but calling your phone system during business hours and after hours. How complicated is the language on that? How many choices do you have? How many branches do you have? Do those branches lead to an actual person ever? You know, does it end in a voicemail that never has gotten checked? That was a big legal case a few years ago, that patients were leaving voicemails and it went to a dead phone, and there's critical things that they were asking about, never answered. It was a multi-million-dollar lawsuit. So listening periodically to phones being answered also, you know, for consistency and accuracy. And then creating scripts. I wrote scripts as a director for all my front staff to say, okay, for new patients, we're going to tell them this is our controlled substance policy right from the get-go. You know, we're going to tell them this is our no-show policy, just a few item things that I wanted to make sure that the patient is going to get multiple layers of paint put on it, especially with the controlled substance one. When in 2014, we wanted to really make sure that patients knew we're not doing chronic pain medication. So the front staff told them, they came in, they saw posters on it, and then by the time they saw the provider, it's not like they're shocked, and they're not going to get upset because they were told already about this. Okay. Yeah, that's that. This is an interesting map here from the University of North Carolina Chapel. I looked at Michigan, the health literacy just in the state here. You can see a lot of green, but as you go further up north, you're getting less and less health literate. This is the Lansing area right here that's red. And this box right here is where Sparrow Hospital is. So we're surrounded by quite a bit of red here, and obviously that's going to drive our readmission rates. So, yeah. There's some interesting websites too that you can use to put in anything that you're writing for a patient to see how readable is your writing. It'll tell you what grade level it's at. And sometimes when we get so far in medicine, we forget, right, how to talk normally. So those are little tips that you can find online. So I think I'll stop for right now. I feel exhausted talking and want to see if you guys have any questions.
A very interesting talk. Thank you, Dr. Hershey. Are there any questions? I think people don't have, they haven't really thought about a question just yet. But if you go back to your page with the contact information, so that you can just, if they have any questions, they can reach out to you.
Sure. So this is Bridge Care's contact info, but I'll show you guys our website here because you can actually send us referrals online. So if you go to refer a patient, you can follow the steps here and there's a referral form. You can also have the patient schedule while they're in the hospital. This is a new feature that we added. So we have a Battle Creek office. We can do Lansing Clinic office, and then we do the virtual, but 90% of our stuff is virtual and they can book right there. And then we access Epic to get all their info. So, and then going back to, there we go. So that's my contact. Okay.
Thank you so much, Dr. Hershey. And then we'll reach out to you if you have any questions. Thank you for giving us this talk. And then we'll take a 5-10 minute break and then we'll resume with the next lecture, guys. Okay.